morning, everyone. It's never easy to hold a presentation before the coffee break, but hold on, in 10 minutes we will finish. So it's actually a great honor for me to have the opportunity to present my PhD topic entitled Current Management of Endometrial Cancer. My name is Madár István. I'm a PhD student and an obstetrician and gynecological specialist. We believe that every endometrial cancer patient's life quality and length can be improved using novel methods. So this is the reason why our mission is to improve the management of endometrial cancer patients by applying up-to-date scientific results. In order to reach our mission, we have proposed two special goals. In the first one, we are going to investigate the systemic therapy for recurrent or advanced endometrial cancer. In the second one, we are going to investigate the transvaginal ultrasound and magnetic resonance imaging in the preoperative stratification of the endometrial cancer. So let's proceed to my first topic. Why do we have to talk about endometrial cancer? Actually, this is the most common gynecological cancer, and its incidence and mortality are rising worldwide. We should bear in mind that 1 out of 5 endometrial cancer patients will have recurrent disease. And unfortunately, there is no standard care for second-line systemic therapy. What we can do in case of recurrent or advanced endometrial cancer disease? We either obtain for local radical therapy, or we do the systemic therapy, which may include hormone therapy, cytotoxic chemotherapy, or targeted therapies. So our clinical question was whether targeted agent-containing therapy protocols offer better survival than the other systemic therapies. We hypothesize that the use of the combined therapy protocols offer better survival rate than the conventional cytotoxic or hormonal containing only systemic therapy. We have done a systemic search and from the 3 major databases, obtaining more than 14,000 results, and in the end, 109 articles proved to be eligible for out of the full texts. After being done with the data extraction, we have sent the data to the statistician, and we have obtained a lot of wonderful forest plots, out of which I'm going to present some. So in the first forest plot, you can see that we have included 3 randomized controlled trials, and you can see that the heterogeneity is 49%, which may be attributed to the different histological composition in the different articles. And you can see that the hazard ratio is 0.77, indicating that the patients treated with the cytotoxic plus targeted chemotherapy have better progression-free survival rate. In our second analysis, we have included bevacizumab-containing chemotherapies. We have included a single-arm analysis as well. And we can see that the heterogeneity is high in both of our forest plots. And we had the suspicion that this might be due to the presence or absence of cytotoxic chemotherapies in the treatment. You can see the progression-free survival at 6 and 12 months. So, as you can see in this aggregate Kaplan-Meier curve, there are basically 2 different groups. So we have done the analysis of these 2 different groups. So in the first one, there was the bevacizumab plus cytotoxic chemotherapy, and in the second one, the novel therapeutic methods, including bevacizumab plus minus targeted therapy. And you can see that the heterogeneity has decreased, and you can see that there is a significant difference between the progression-free survival with regards to the 6 and the 12 months progression-free survival probability. And the result is almost the same at the 18th month's survival. In our fourth analysis, we have included the mammalian target of rapamycin pathway containing chemotherapeutic methods. These were mostly single-arm studies, and you can see that there is a high heterogeneity here as well. And we suspect that this might be due to the pre-treatment variation in the pre-treatment period. Just the same can be observed at the 12 months progression-free survival rate. And we can observe here that one out of 4 patients are likely to survive 12 months with this therapeutic scheme. And you can see that only 8 articles out of the 13 analyzed articles offered progression-free survival rate at 18 months. And approaching the end of the presentation of my results in the first topic, I'd like to show you on the second figure the pooled progression-free survival rate with the specific confidence interval, and you can see in this picture as well that the heterogeneity is really high. So let's move forward to my second project and towards the coffee break. In our second project, we will discuss about the transvaginal ultrasound and magnetic resonance imaging in the preoperative stratification of endometrial cancer. I've already highlighted the importance of endometrial cancer and doing research about endometrial cancer. And also I would like to underline that the proper myometrial infiltration assessment would lead to better surgical planning, which on the end will result in reduced, unnecessarily extended surgery. The most common techniques at the myometrial infiltration assessment are the transvaginal sonography and the magnetic resonance imaging. So our clinical question was whether transvaginal ultrasound have similar performance as MRI in the preoperative myometrial infiltration assessment. And we hypothesize that ultrasound indeed has similar performance as MRI in the preoperative myometrial infiltration assessment. And the clinical implication would be the reduction of costs and unnecessary extended operations rate through better preoperative patient stratification. So, approaching the end of my presentation, I'd like to underline once again the planned submission dates. The first project we intend to submit in June, the second one about the end of the year. And finally, I'd like to thank you for your endurance, for your patience in the end, with the quotation from Arnold Palmer, the king of the golf. Always make a total effort, even when the odds are against you. Thank you very much.
In your first study, you show this kind of heterogeneity, and then you use the term that we suspect that the pretreatment. So this is actually based on real, all studies detailed if there was a pretreatment or not. And were there individual studies when there were pretreatment and no pretreatment? Because that would be the ultimate kind of proof for this.
Yes, most of the studies are including patients both from the untreated, pre-treated group and from the heavily pre-treated group. So this is actually might be a source of heterogeneity and a source of bias actually, but due to the reduced number of the articles, I'm not exactly sure how can we interpret these results. But I will talk in the end with our mentors and supervisors, and we will interpret. This is actually a limitation, but I've seen many meta-analyses including these. Including such articles, and they all say in the end that there is a limitation, but there's a
But I
consequence.
think this is more the limitation. This is going to be a very important message of your paper. I mean that these kind of preconditions are actually very much affect the outcome, so therefore that must be reported.
Yes, and I'd like also to add that there are many, many randomized control trials ongoing. So within 5 years, we will have at least 5-10 randomized control trials in this topic. Yes, right now we don't have too much, but within 5-10 years we will have a lot of randomized control trials, and there might be a shift of paradigm in the end.
And the final comment before the coffee break, perhaps between the ultrasound and the MRI, there is a big difference in the person of the examiner, because ultrasound in most cases done by gynecologists, oncologists, and MRI in a lot of cases evaluated by radiologists. So in this case, in an expert ultrasound examiner, ultrasound might be better than MRI because of the examiner.